Today we are having a topic on fall. I have not mentioned fall where. So, we have heard of the story Jack and Jill went up a hill to fetch a pail of water. Jack fell down and broke his crown, and Jill came tumbling after. This was when they were small children. Now they have grown up. This I learned this poetry 60 years back. So obviously they have also grown up now. So now it is Jack and Jill went up the hill to fetch a pail of water. Jack fell on his outstretched palm, and Jill came down with a fracture. Okay? So for an outstretched palm and fracture-like fever. Fracture-like fever is common in elderly osteoporotic female now who is Jill. Let's start with fall and the outstretched palm. See, if you take a hammer and hit a bone, the bone will break there. This is called as direct trauma. But when you are falling on the outstretched palm, any of the metacarpal phalanges can break. That's called direct trauma. But objects which are not hitting the ground, they also can get broken because of the transmission of forces. So that's called as indirect trauma. Or transmission of forces, indirect trauma. So the first thing which can break is the scaphoid bone, fracture scaphoid. Now scaphoid is a bone, you can have a look at it tomorrow. It has got a swollen distal end, it has got a swollen proximal end, and a narrow constriction between. Scaphoid, boat shaped, swollen distal end, swollen proximal end, with a narrow waist in between. This is called as fracture waist scaphoid. Now, scaphoid is supplied by recurrent branch from the deep palmar arch. So it's not supplied by radial artery, it's not supplied by ulnar artery, it's not supplied by anterior interosseous artery. It is supplied by recurrent branches from the deep palmar arch. Now, distal part of the scaphoid will get the blood supply. But when there is fracture waist scaphoid, if that artery is also involved, then the proximal part of scaphoid will suffer from avascular necrosis. So fracture waist scaphoid may complicate as avascular necrosis of the proximal part if the blood vessel also gets involved in fracture of waist scaphoid. Is it clear? Next, fall in the outstretched palm can cause lunate dislocation. Lunate has got a broad anterior end and a narrow posterior end, unlike all other carpal bones. So lunate can't dislocate posteriorly because the anterior part is broad, posterior part is narrow. Through the narrow space, lunate can't dislocate posteriorly. So, lunate dislocates anteriorly. Now, this is absurd. You are falling on the palm, impact is downward, the downward push is up, backward. How can lunate dislocate in front? So this reminds me of that story from Dhamal, where there are 8 people standing as you, and the inspector asks, who wants to die first? So everybody tap. He was enthusiastic to see. After the dust settled, he saw only one person is standing. All others took one step behind. And this fellow was so tired, he could not even one step behind. So you fall on the outstretched palm, scaphoid, triquetral, pisiform, trapezium, trapezoid, capital, diamond all move behind. Metacarpus phalanges, the radius, Allah, everything moves behind. What is left behind is lunate in its place. So, and lunate appears anterior dislocation. The correct terminology should not have been lunate dislocation. It should be called as perilunate dislocation. Dislocation of all structures except lunate. Perilunate. Would we call it as lunate dislocation? Irrespective of what you call it, lunate has come anteriorly. The carpal tunnel space is reduced. Once the carpal tunnel space is reduced, 9 tendons and 1 nerve pass through the carpal tunnel. 4 tendons are superficialis, 4 tendons are profundus, and 1 flexor pollicis longa. These 9 tendons, their blood supply can be compromised. So it will result in friable tendons. Tendons can get separated from their attachments. Tendons, synovial sheath surrounding them for lubrication, can get inflamed. It need not be only delivery dislocation. Hypothyroidism, myxedema can result in accumulation of fluid in the carpal tunnel. But more than any of the tendons, the most susceptible structure is the median nerve. So median nerve is what is getting involved. This median nerve, as it comes to the palm, it gives a recurrent branch to the thenar muscles. So those are gone. So you can't count finger, you can't oppose. Opposition is gone. So the thumb lies in the plane of the other finger. Now if you look at humans or monkeys, when they catch hold of any object strongly, thumb will be on one side, 4 fingers are on the other side. In apes and people with carpal tunnel syndrome, all 5 fingers will be on the same side. That's why the hand is called as ape hand deformity. Ape hand deformity in carpal tunnel syndrome. Another thing which will be seen is that the thumb, index finger, middle finger, and half of ring finger, that will be sensory loss. 3.5 fingers, sensory loss, including the nail bed. 1.5 fingers is supplied by ulnar. 3.5 fingers are supplied by median nerve. But point to be noted is the palm, lateral 2/3 of the palm is also supplied by median nerve, but that is not affected. Lateral 2/3 of the palm, although supplied by median nerve, is not affected in carpal tunnel syndrome because the palmar cutaneous branch of median nerve is given off in the forearm. And then it comes to the palm, passing superficial to the flexor retinaculum. So that is not going to get involved. Yes, if you fall on a glass, then, and there is a superficial cut, then that nerve can get involved, median nerve will be spared. And ulnar nerve, which is passing in front of the flexor retinaculum through a space called as Guyon's canal, G-U-Y-O-N, Guyon's canal, that can get affected. So superficial injury, damage to ulnar nerve, superficial branch of median nerve. Deeper injury like carpal tunnel syndrome, median nerve without the cutaneous branch to the palm and without ulnar nerve being involved. Is this clear? What will happen if the ulnar nerve gets involved? Now, all introosseae of the hand are supplied by ulnar nerve. Now, palmar introosseae adduct, dorsal introosseae abduct. So fingers are spread out in dorsal introosseae. They are together in palmar introosseae. Pad and dab, palmar adduct, dorsal abduct. But the combined action of the palmar and dorsal introosseae, their adduction abduction will be cancelled out. Instead, they will flex the metacarpophalangeal joint and extend the interphalangeal joint. Flex the metacarpophalangeal joint and extend the interphalangeal joint. This is also the role of lumbricals. Flex the carpometacarpal joint, extend the interphalangeal joint. So this position of the hand, where there is flexion of carpometacarpal and extension of interphalangeal, is called as intrinsic plus. Intrinsic plus position of the hand. Intrinsic plus because intrinsics are active. In contrast, if the intrinsic muscles are paralyzed, hyperextension of metacarpopharyngeal joint and flexion of interphalangeal joint. That's called claw hand. So claw hand is intrinsic minus position. Claw hand is intrinsic minus position. In ulnar nerve damage, 8 interossei are paralyzed, palmar and dorsal. And 2 lumbricals are also paralyzed, the lateral, medial 2 lumbricals, ring finger and little finger. So ring finger and little finger will go into severe claw. Index finger and middle finger will go into lesser claw because lumbricals are intact. 2 lumbricals are supplied by median now. Are you getting the point? So injury to median nerve at carpal tunnel results in opposition loss and 3.5 finger loss. In ulnar nerve damage, it results in clawing of the ulnar fingers. They are also called as ulnar claw. Now, all intrinsic muscles of the hand are supplied by median nerve or ulnar nerve, but they come from the root value T1 of spinal cord. Ulnar nerve has a root value C8 T1, median nerve has a root value C5, 6, 7, 8 T1. The T1 root value is meant to supply the intrinsic muscles. So if T1 root is damaged, that results in club case paralysis. Then you get complete claw because all intrinsic muscles of the hand are paralyzed. Also, if median nerve and ulnar nerve both are damaged, that will also result in complete claw. And they can both get damaged in the just above the elbow, where they are lying in front and behind the humerus. How do you differentiate whether the complete claw is because of median ulnar damage or is it because of T1 spinal segment damage? So there you go by sensory loss. If median and ulnar both are damaged, the entire palm will be anesthetized. Whereas T1 damage will only be inner border of the upper limb. We know cardiac pain is inner border of the upper limb. Are you getting the point? So that's how you differentiate whether it's median ulnar together damage or is this T1 spinal segment damage. Okay. Moving proximally, the next bone to be damaged is the radius, distal part of radius, or shaft of radius, or neck of radius. So 3 parts it can get affected. The distal end of radius, middle shaft, or proximal part neck. In elderly individuals, the most common is distal part of radius getting broken. That was described by a scientist called as Colles, C-O-L-L-E-S, and that's called as Colles fracture. In Colles fracture, what happens to the distal fragment? The distal fragment will tilt dorsally, will tilt laterally, and will rotate laterally. Okay? Tilt dorsally, tilt laterally, and rotate dorsally. So, and the brachioradialis, which is inserted on the styloid process, pulls the segment proximally. The brachioradialis pulls the segment proximally. So, there is spontaneous union the distal of radius and the revealing part of radius. Unfortunately, they they don't align, they get malaligned, but they heal. So you have to take care that you have to align the bones before it is allowed to heal. So you have to do a traction and then realign the bone so that the tilt and the rotation is taken care of, and then you allow the healing to occur, immobilization. So if you allow it to malalign, what will happen is there will be a hump on the dorsal aspect of the wrist. A hump on the dorsal aspect of the wrist with the four fingers almost look like a dinner fork deformity. The forearm is considered as a handle of the fork. The hump is the dinner fork which is always curved, and fingers are the prongs of the fork. So Cooley's fracture or malunion results in dinner fork deformity. Fracture of the shaft radius, what will happen to the distal segment? That will depend on whether the fracture has occurred distal to the insertion of pronator teres or proximal to the insertion of pronator teres. Pronator teres is the pronator which is attached to the middle of the shaft of radius. If the fracture occurs beyond the insertion, proximal part will get pronated. Relatively, the distal part will get supinated. So when you want to cause a union, you have to rotate the distal part medially and then allow malunion, then allow proper union. If the fracture is proximal to the insertion of pronator teres, distal segment will get pronated because pronator teres insertion is there. Proximal segment will relatively supinate. The distal fragment has to be supinated to allow proper union. Fracture neck radius, there is a chance of a deep branch of radial nerve. It's also called as posterior interosseous nerve, which is going to the dorsal surface. That may get trapped. The nerve can get trapped in the proximal neck of radius. Remember, when a nerve is close to the bone, it may get involved in the fracture. When the nerve is close to the skin, it may get involved in a slash injury. Best place for the nerve to be is between the two muscles. This deep branch of radial nerve is close to the neck of radius, so that may get trapped in the neck of radius. But point to be noted, usually when we say radial nerve, we think of wrist drop, because all wrist extensors are supplied by radial nerve. But extensor carpi radialis longus, extensor carpi radialis brevis, both these muscles are supplied by a radial nerve before it passes around the neck of radius. So when the radial neck is fractured, which results in damage to radial nerve, the two extensors of the wrist are spared. So there is no complete wrist drop. In fact, there will be finger drop. That means metacarpophalangeal joint will be flexed. It's called finger drop, not wrist drop. Same radial nerve, if it is damaged in the fracture of the shaft of humerus, it can result in wrist drop. Because at that point it has not supplied extensor carpi radialis longus and brevis, it has not supplied any other extensor of the wrist. So there will be wrist drop. That's about radius. The impact from the radius can also transfer to Allah through the interosseous membrane. So Allah can get fractured at its proximal part. Remember, Allah is not a part of the wrist joint. And therefore, fall of the outstretched palm does not involve Allah normally. But proximal part of Allah can get involved because the impact from radius through intracranial membrane can reach Allah. Another point to be noted is when you fall, unless you have enough time, you may not always fall on the palm. You may fall on the dorsum of the hand. When you fall on the dorsum of the hand, the commonest fracture which occurs is the distal part or radius. But because you fall on the palm, the radius will get ventrally tilted, medially tilted, will be supinated and pulled proximally. This malunion is called as Smith's fracture. In fact, this fracture is called Smith's fracture, reverse of Colles fracture. So in Colles fracture, you fall on the palm, the segment is tilted dorsally. Here, the segment will tilt ventrally. Okay, Smith's fracture. The next in sequence to be affected in the fall of the outstretched palm is elbow joint. Remember, in elbow joint, there are two medial and lateral epicondyles which you can palpate, and back of the elbow there is an olecranon process which also you can palpate. And if you notice the relation of medial epicondyle of humerus, lateral epicondyle of humerus, and olecranon process of Allah, in extended position they lie in one line. In flex position, they form an equilateral triangle. Okay? So this relation is important to be known because in elbow dislocation, this relationship is damaged. Now, if the person's hand is in the extended position, check whether these three bones are in one line. If the hand is already in flex position, check whether they form equilateral triangle. You can't say, I will study only anatomical position. Then they lie in one line. That means the broken elbow, you don't know the relation in rex position. You will ask the person to show me extended position. Then only I will know whether it is. You can't ask the person with broken elbow to extend the elbow. So you have to know the relation in whatever be the position of elbow. In that position you have to check whether that relation is disturbed or not. Notice, if there is fracture, next fracture is supracondylar fracture. If the fracture is above the two epicondyles, the relationship of epicondyle and olecranon is not disturbed. So that's how you differentiate supracondylar fracture from elbow dislocation. Both the pain will be around elbow. But in supracondylar fracture, because above the two epicondyles, epicondyle olecranon relation is not disturbed. But if it's a complicated supracondylar fracture, which horizontal with a T vertical component, where the ulnar medial epicondyle is fractured, T-shaped fracture, supracondylar and olecranon, supracondylar and medial epicondyle. If it complicates, the relation will be disturbed. Otherwise, pure supracondylar fracture, it doesn't change. Supracondylar fracture is commonly seen in adolescent people. Okay? So as we said, in old age, Colles fracture is common. In adolescent, the supracondylar fracture. In adult, it is fracture clavicle. And what about a child? See, adolescent supracondylar, adulthood clavicle, old age Colles, young age no fracture. Their bones are very pliable, so no fracture occurs. Right. So we discussed about young individuals, no fracture. Adolescent, fracture supracondylar. Adult clavicle and old age Achilles. Now let's talk about supracondylar fracture. The cut edge of the fracture turns anteriorly. So the ragged edges cut through the structure which lies in front. And what lies in front is the median nerve. Ulnar nerve is behind the medial epicondyle, so it's often spared. Okay? One would expect that ulnar nerve is close to the medial epicondyle. But the cut ends turn anteriorly. Median nerve is damaged. The difference between median nerve in carpal tunnel syndrome and the median nerve damage in fracture of the supracondylar would be, in addition to the ape-hand deformity, there will also be a pointing fist. When the person is asked to make a fist, the role is of flexor digitorum superficialis and flexor digitorum profundus. Superficialis is completely supplied by median, but profundus has got half supplied by ulnar and half supplied by median. So that half which is supplied by median undergoes paralysis, but the half which is supplied by ulnar will be intact. So two fingers will flex when you try to make a fist. So this is called as hand of benediction. So when Pope gives the blessings, his two fingers are extended and other fingers are flexed. Sometimes, because of mass action, middle finger is also flexed. Because the fleshy fibers of flexor digitorum profundus are not separated out. The four tendons are not separated out. Index tendon is separated. Middle finger is with the rest. So when the rest of the muscles contract, middle finger also contracts, pointing index or pointing fist. So ape-hand deformity, pointing fist deformity. That's why in one of the older books of orthopedics, he had given a jingle about this median nerve which is cut at the elbow. He says, if your median nerve is cut through, your buttons are hard to undo. The front of your thumb and three other fingers are numb, and your fist points the way to the loo. If your median nerve is cut through, your buttons are hard to undo. Because the position is gone, if you try to open the button with one hand, it will be difficult. The front of your thumb and the other fingers are numb, and your fist points the pointing fist. Way to the loo is only to rhyme. What will happen if the ulnar nerve is damaged? Ulnar nerve can also get damaged in supracondylar fracture. You will get similar picture as hand damage, because most of the ulnar nerve supplies the hand muscles. So you will get ulnar claw hand. Here lies the difference. The flexor digitorum profundus medial half is also paralyzed, which is supplied by ulnar. So the person will get clawing, but the claw will be weak. Because clawing flexion component requires flexor digitorum profundus. That half is paralyzed. So damage at elbow, clawing is less. Damage at wrist, flexor digitorum profundus is spared. The clawing will be worse. So this is called as ulnar nerve paradox. How is it that distal damage should affect lesser fibers, should produce lesser deformity? Proximal damage affecting more fiber should produce greater deformity. But that's not so, because of the flexor digitorum profundus. If flexor digitorum profundus is paralyzed, clawing will be less. If flexor digitorum profundus is spared, clawing would be worse. If the nerve is cut completely, will it heal or will it die? Initially, there will be volar degeneration. Distal segment will undergo degeneration. Then, the proximal segment will start growing. If it gets the distal segment which is almost degenerated, new branches will pass through that existing epidural sheath and reach the hand for nearly complete recovery. But the growth of which the nerve regenerates is 1 inch per month, 1 millimeter per day, 5 Sundays, 25 millimeters per month. And it takes that is the speed. You cannot do anything to hasten the speed. At the most you can supplement with vitamin B12 so that the healing at least occurs at its necessary speed. So if the ulnar nerve is damaged at the elbow, it will take around 9 to 12 months for complete healing to occur. So that was the distance. If the ulnar nerve is damaged at wrist, it will take 2 to 3 months to heal. Are you getting the point? Moral of the story, when a patient comes to you and you are the orthopedic surgeon, you know you can do nothing about it. So you can give him vitamin B12 just for his satisfaction. And then it will heal. But if you have not alerted your patient, after some time when the nerve heals partially, the flexor digitorum profundus starts healing, recovering first, and the clawing worsens. The patient is alarmed. I have been taking treatment for the last 3-4 months, and now your condition is worsening. So he loses faith in you. He goes to another orthopedic surgeon. And the other orthopedic surgeon is smart. He knows what is the situation. He says, when did you get the damage? He said, 4 months back. So what are you doing for last 4 months? So I went to that orthopedic surgeon. Oh, he is completely useless. You should have come to me. I would have healed you in 2 months. He is saying that. But now your condition is bad. Now it will take around 6 to 9 months more. Basically, we are trying to buy time. He says, whatever you say, doctor, I will do whatever you say. He says, what tablet was he giving you? Oh, he was giving that blue colored tablet. Arey, that's a wrong tablet. You give a vitamin B12 only of a different company, the color is red. And then in 6 months' time he heals. We should have anyway that. Other also he would have anyway. So that doesn't mean you wait for him to go to another surgeon. You explain to him that I will be taking and will give you treatment. It will take 9 to 12 months for you to heal. After few months, your condition will appear worse, but that's a good sign. It's a sign that healing is taking place. You explain that, then he understands. He say, no, but that other doctor said he will heal me in 2 months. So then go to him. 2 months later, he'll come back to you. Because nobody can heal at faster than 1 inch per month. Are you getting the point? So ulnar nerve paradox must be explained to the patient. Not that this is ulnar nerve paradox. Just tell him that initially your signs will appear worsening. That's a sign of healing. Are you getting the point? And we already discussed what will happen if median ulnar nerve both get damaged. In that case, complete claw. Okay? More than these two nerves affected, here is one area where the brachial artery can get damaged. Just like next to the median nerve is brachial artery. So the cut edge can cut through brachial artery. In which case, There will be a lot of swelling in the forearm and the hand, and the muscles will be fibrous because nourishment to muscles is compromised because the vessel has been cut. So it will be replaced by fibrous tissue, which requires very less nourishment, and fibrous tissue has a tendency to shorten. So muscles replaced by fibrous tissue undergo a shortening. This is called as contracture. Described by a scientist called as VOLKMANN. Now V in German is pronounced as F. L is silent. So actually it's called as Folkman's ischemic contraction. We call it as Volkmann. Folkman. Okay? V is properly pronounced as F. Folkman's ischemic contraction. Okay? What happens is the wrist flexors and wrist extensors. You can easily make out that wrist flexors are bulkier muscles. Wrist flexors are bulkier than extensors. So the wrist will be contractured in a flexed position. Wrist will be contracted in a flexed position. Metacarpophalangeal joint. Forearm extensors are stronger than lumbricals and interossei. Forearm extensors are stronger than lumbricals and interossei. So metacarpophalangeal joint will remain extended. Interphalangeal joints is done by flexor digitorum profundus and superficialis, which are stronger than lumbricals and interossei. So fingers will remain flexed. So elbow, wrist flexed, metacarpophalangeal extended, fingers flexed. That is the position of what is called as Michelangelo's hand. Michelangelo drew a hand with the wrist flexed, metacarpophalangeal extended, and fingers flexed. One wonders why such a famous painter has drawn such clumsy hand. Probably the subject which he had was suffering from Folkman's ischemic, and he drew that. And so that's the contracture which can develop after damage to brachial artery. Let's proceed a little higher up. Fracture of shaft of humerus. In the spiral groove behind the shaft lies the radial nerve. This radial nerve can get involved in fracture of shaft humerus. Remember, in the supracondylar fracture and in the fracture of shaft of humerus, many a times the nerve is not involved at the time of fracture, but the fracture heals. When the fracture heals, at that time the soft callus and the hard callus will trap the radial nerve with it. So you don't get the radial nerve wrist drop immediately. You get it later, during healing process. And similarly, the ulnar nerve, we said normally is not involved in supracondylar fracture and will not be involved. But you might find some weeks to months after the fracture is healed completely, ulnar nerve starts showing the paralysis. Such type of paralysis is called as tardy ulnar paralysis. Tardy, slow, retarded, slow, delayed ulnar paralysis. Similarly, you can get delayed radial paralysis. You may get it immediately also, but you can get a chance of delayed union. During a reunion, there will be wrist drop. Anterior to the anterior to the humerus is brachialis. Anterior to that is biceps brachii. Between the two, between the biceps and the brachialis, lies the musculocutaneous nerve which supplies both of them. So musculocutaneous nerve is neither close to the bone, so does not get involved in fracture. Musculocutaneous nerve does not get involved in slash injuries because it's deeper to biceps. Musculocutaneous nerve damage is seen only in MCQs. In real life, you hardly get it. Sometimes it may get trapped between the two heads of coracobrachialis through which it passes. But then coracobrachialis is too weak a muscle to usually cause any problem. But you have to know that musculocutaneous nerve supplies biceps brachii, coracobrachialis, brachialis, and it supplies cutaneous to the lateral part of forearm. Because MCQ there is no guarantee. Going further up, you can get fracture of surgical leg of humerus. Fracture surgical leg of humerus or shoulder dislocation. In both these cases, there is an axillary nerve which is winding around the surgical leg of humerus which may get involved. The axillary nerve supplies deltoid. And teres minor, that's not important, supplies deltoid. And deltoid is a strong abductor of the shoulder joint after 15 degrees. So you want to know whether the nerve is injured or not. Because if it is injured, you have to surgically repair the damage. If it is not injured, you can do a close reduction. Okay? Shoulder joint is the most commonly dislocated joint. In fact, sometimes it's so recurrently dislocates that we have Rohit Sharma, who has got a recurrent dislocation of his left shoulder. So once he dived to upper part and he stretched his elbow and the shoulder got dislocated, he just used the other hand and repositioned the humerus back. So recurrent dislocation is not that painful. But you have to make sure axillary nerve is not trapped. So how do you test the axillary nerve? You ask him to abduct the shoulder with great resistance after 15 degrees. But how can a person abduct the shoulder which is dislocated? Then how do you know the axillary nerve is damaged or not? So you use the cutaneous component of axillary nerve. Axillary nerve supplies the skin over the lower half of deltoid. Axillary nerve supplies the skin over the lower half of deltoid muscle. The upper half of deltoid is supplied by supraclavicular, lateral supraclavicular nerve from cervical plexus. And the lower half of deltoid is supplied by axillary nerve. So you test for the cutaneous supply to check whether the nerve is damaged or not. Okay? So after the surgical leg and the dislocation of shoulder, the next impact will be on scapula, which is usually not fractured. If it gets fractured, scapular fracture does not require any immobilization because all the muscles attached to scapula will hold it in place. Now comes the prime. From the scapula, impact reaches the clavicle, but not through the acromioclavicular joint. It reaches the clavicle through the coracoclavicular ligament. Coracoid process scapula to clavicle. And then from clavicle, it does not go to the sternum, through sternoclavicular joint. It reaches the first rib through the costoclavicular joint. So neither ends of clavicle has got impact. Only the middle part of clavicle carries the impact. And then, if the clavicle breaks, theoretically it could break anywhere in the middle part, but always breaks at the junction of medial two-third lateral one-third. Why? 6 reasons. 1. Change of shape of clavicle. The clavicle is quadrangular in the medial two-third. It is flattened in the lateral one-third. This is the main reason. Change of curvature of clavicle, shape of clavicle is what is responsible for the break. Change in curvature. Medial two-third is convex anteriorly. Lateral one-third is concave anteriorly. Lateral. So change in shape. First was change in shape, second is change in curvature. Third, medial two-thirds has got the attachment of clavicular fibers of pectoralis major. Lateral one-third has got the attachment of deltoid and trapezius. The junction between the two is devoid of muscle attachment, so that can break. Fourth reason, the nutrient artery of clavicle pierces the clavicle at the junction of medial two-third, lateral one-third. And the nutrient foramen is located at the junction there. So nutrient foramen whole means slight weakening, break. At times, from the branch to the cervical plexus, intermediate supraclavicular nerve. Intermediate supraclavicular nerve passes through the clavicle at the same junction, weakening the junction further. That's not that intermediate supraclavicular nerve. Where is the clavicle? Where is the clavicle? Let me hear that. The nerve is already there. The clavicle has formed around it. So nerves don't pierce bone. Bones are formed around the nerve. So that causes the weakening. And the sixth reason, probably the least important reason, medial two-third of clavicle has a separate ossification center, lateral one-third has a separate ossification center. This appears to be a very strong point, but these two ossification centers fuse very early in embryonic period. If it fails to do so, obviously it will result in weakening. But they fuse very early. And this fracture clavicle when it occurs, 25-30 years of age, adulthood. By the time the bone is one single strong bone. But these are the reasons mentioned why clavicle breaks, where it breaks, junction of medial two-third, lateral one-third. So this was about Jack fell on his outstretched hand and Jill came down with a fracture. Now, elderly osteoporotic females sleeping in the bathroom. When she's sleeping in the bathroom laterally, the adductors go into strong contraction. The adductors go into strong contraction to prevent the fall. But that strong contraction of adductors against abductor forces of sleeping results in fracture of femur. And where fracture and the least strength, neck of femur. Now, fracture neck femur are of 4 types. Just below the head is called subcapital fracture. A little beyond that, but intracapsular fracture neck. Further lateral, extracapsular fracture neck, or IT fracture, the intertrochanteric fracture. Okay? So you have 4 types of fracture: subcapital, intracapsular, extracapsular, and IT. Now, Medial to the greater trochanter lies the trochanteric anastomosis. Trochanteric anastomosis is formed by superior inferior gluteal and medial and lateral circumflex femoral. Out of these four, the medial lateral circumflex femoral mainly supplies the head of the femur in an adult. The medial circumflex femoral from this trochanteric anastomosis supplies the head of the femur in an adult. In a child, the head of femur is supplied by obturator artery, traversing the ligamentum teres, the round ligament of head of femur. Now, why is the difference? The obturator artery is a very small artery, small branch of internal leg. It can supply the head of the femur only in the child when the head is small. But as the head enlarges, obturator cannot supply. So, medial circumflex femoral comes into play. But why not in the child? Between the head of femur and the neck of femur, there's a growth cartilage, hyaline cartilage. And cartilages are avascular. So, avascular cartilage will not allow the artery to supply the neck, also to supply the head, because there is an avascular plane. So, till that time the bone unites, obturator artery will supply. Then the obturator artery has become so small that it has got enough blood only to supply the ligament, not the head. Therefore, in an adult, a subcapital or an intracapsular fracture like femur has got a chance of avascular necrosis of femoral head. Okay? Whereas if it's an extracapsular or IT fracture, this artery is spared, so it can continue to supply that. So why certain fractures cause avascular necrosis of head of femur and why certain fractures don't? Now, let us look at the position of the patient. The lateral rotators of hip joint are gluteus maximus, 6 short lateral rotators piriformis, superior inferior gemellus, superior inferior obturator, obturator internus externus, quadratus femoris. So there is the 6 muscles. Piriformis, 2 gemelli, 2 obturators, and quadratus femoris. These 6 muscles are called as short lateral rotators. So gluteus maximus, 6 short lateral rotators, and sartorius. These are the muscles which laterally rotate the femur. Now what are the structures which medially rotate the femur? Anterior fibers of gluteus medius and minimus, rectus iliopsoas, and adductor longus. So anterior fibers of gluteus medius minimus, iliopsoas, and adductor longus. These muscles cross the hip joint anteriorly. That's why they medially rotate. The moment there is fracture of neck of femur, the axis of rotation, which was originally passing through the head of femur, now becomes the shaft of femur. Because of the fracture of the neck, the axis of rotation becomes the shaft of femur. Now, gluteus maximus, 6 short lateral rotators, sartorius, continue to laterally rotate. Anterior fibers of gluteus medius minimus continues to medially rotate, but iliopsoas and rectus femur and adductor longus, because they are inserted on the posterior part of the shaft, they suddenly start rotating laterally. So you get a severe imbalance between medial rotator and lateral rotator, and you will find that the foot is extremely laterally rotated. If you go to an orthopedic ward and see a lady lying there and you ask her, what happened? She realizes you know nothing. There's no point in explaining to you. Instead, if you look at her foot, one foot is pointing towards the ceiling, the other foot is turned outward. You ask her, when did you slip in the bathroom and break your bone? Wow, impressed. He did not look at the case paper, yet he came out with this question. So then rapport is developed. So you don't have to ask which foot is damaged. You'll be able to make out by looking at the position of the foot and usually sleep in the bathroom. The point to be noted, our history, I fell in the bathroom and broke my bone. That's our history. Real history is like this. She was sleeping in the bathroom. She tried to prevent the slipping. The bone broke and then she fell. So it's not the fall which breaks the bone. It's the broken bone causes the fall. In fact, if you had actually fallen, the femur will not fracture because it's covered from all sides by muscles. Why will it fracture? It will be protected. Moral of the story, when you are sleeping in the bathroom, slip. Nothing will happen to your femur. Yes, head injury, other things can occur. Anyway, we don't plan and fall, right? And the adductors don't plan and contract. Yes, reflex contraction and bone broke. But remember, it's always the break of the bone which causes the fall. Although they will say, because it happens so simultaneously. They say, I fell and therefore I broke.
I think because of epilepsy, this clavicle fractures happen in the same way. In epileptic patients, during the tonic-clonic contractions,
Yes, full of muscles.
full of muscles.
One part moves it down, the other part moves it up, and distraction. So, with that, we come to the end of discussion of fall or outside stand and fall. In fact, there was a person from England. He said, Jack fell down. This fell down is wrong. He says fell. You can only fall down. You can't fall up, right? And yet we use the word fell down. Because we have learned Jack and Jill. Okay? Shall we stop here?